Welcome, everyone. Thank you for joining today to be part of this important conversation on improving access to contraception. My name is Emily G., and I'm Senior Vice President for the Inclusive Growth Department at the Center for American Progress. Equitable access to contraception is acutely important in the current moment. We women in America face profound uncertainty over our ability to determine our own reproductive health and face monumental shifts in reproductive rights. The impact of the U.S. Supreme Court's stunning Dobbs decision last June, which overturned Roe versus Wade and abandoned 50 years of precedent, is being only compounded by the growing hostility in many states from lawmakers who are moving to further restrict reproductive rights and assert control over women's bodies. More than ever before, we need courage and support from policymakers at all levels of government to advance bold, progressive policies to bolster bodily autonomy and family planning. The reality that we face in the United States is that your access to contraception depends on where you live. The patchwork of state policy layered upon the social and economic factors Americans face as individuals and in their communities means that many people live in areas without the full spectrum of contraceptive options or their preferred method. As a result, more than 19 million women in the United States live in so-called contraceptive deserts and have inadequate access to the full range of birth control methods. In this sobering environment, one thing that gives me hope is the work that my colleagues of CAP's Women's Initiative have been doing to meet this moment. They are providing leadership in the progressive community and maintaining a proactive agenda on women's health and rights. They are putting forth policies and ideas that advance the ability of women and all people to decide for themselves whether, when, and how they want to have children, and helping create an environment with optimal conditions to support these choices. CAP's Women's Initiative recently released a series of reports on state-level policy options to improve access to birth control. In numerous instances, states have been at the forefront of innovative policies to lift the structural, institutional, and administrative barriers to contraceptive care. CAP's organizations are organized around the following themes. First, implementing a 1-year or extended supply dispensing policy for contraceptives, increasing the traditional 1 to 3 month quantity limits in private insurance plans, and public programs like Medicaid could help expand access to contraceptives. The second theme is improving and expanding pharmacist prescribing authority and practices, thereby allowing pharmacists in the community to both prescribe and dispense hormonal birth control. Since 2020, 10 states have expanded pharmacists' prescriptive authority over contraceptives. The third theme is expanding family planning benefits through Medicaid Section 1115 waivers and state plan amendments with changes to support patient awareness and enrollment. And finally, establishing contraceptive quality measures, which are crucial to identifying areas for improvement, identifying gaps, and informing adjustments to care delivery and reimbursement. These types of reforms have the potential to dramatically improve the way people receive contraception and contraceptive services. I hope that those of you watching today will take a look at this series, the latest installment of which was published this morning. No policy and no conversation on this topic is complete without considering equity. We know that the most marginalized groups experience the greatest barriers to care, both in general and for contraceptive care specifically. And that includes people of color, low-income people, LGBTQI people, and those who live in the Deep South and rural communities. All too often, policy reforms don't reach the people who are most in need. That's why it's imperative that we examine this angle and ensure that we prioritize reforms that reach those who need it most. Today's conversation will do that. Research also shows us that accessible and affordable birth control does matter. It supports not only improved health outcomes, but also better economic stability. Access to birth control before age 20 is associated with lower likelihood of living in poverty, greater lifetime earnings, and better educational outcomes. Today, CAP is honored to be joined by 3 champions for reproductive health and rights to discuss how we can move toward a collective vision for improving contraception access. Over the next hour, they'll share their experiences providing care and advocating for better health care and reproductive health. Thank you so much, Amy Fan, Tara Mancini, and Kim Diaz Scott for being part of this conversation. I now welcome them and Kiara Jones, a policy analyst for CAP's Women's Initiative, who will be moderating this discussion.
Thank you so much, Emily, for that kind introduction and your inspiring remarks. Hi, everyone. My name is Kiara Jones, and I'm a policy analyst here with the Women's Initiative at the Center for American Progress. And I'm thrilled to be able to moderate today's conversation between our panelists. I'm honored to introduce our esteemed and incredibly knowledgeable panelists, Tara Mancini, Amy Fan, and Kim Diaz-Scott. Our first panelist, Tara Mancini, is the Director of Public Policy at Power to Decide. They work with grassroots organizations as well as policymakers to advocate for better contraceptive policy that improves and expands access to birth control. In 2017, Tara launched Power to Decide's state policy project, which focuses on policies that improve information about and access to contraception. And they also spearheaded the Advancing Contraceptive Access Toolkit in 2020. For this work, Tara received a 2021 Excellence in Advocacy Award from Women in Government Relations. She previously served as a Senior Manager of Public Policy at Power to Decide and as a research assistant at the Georgetown University Center for Children and Families. Thank you for being here, Tara. We are eager to hear more of your vast expertise. Our next panelist is Amy Fan. Amy is the co-founder of Twentyeight Health, which is a mission-driven digital health platform increasing women's health access for underserved communities, focused on inclusive care for Black, Indigenous, and communities of color, and individuals from low-income backgrounds. Twentyeight Health provides telemedicine, medication delivery, and follow-up care, and is one of the only telehealth platforms to accept Medicaid. Previously, Amy was the general manager of Onami Beauty, a direct-to-consumer beauty startup, and a consultant at Bain & Company. She was recognized as Rock Health's Top 50 in Digital Health in 2021 and Inc.'s Female Founder 100 in 2022. Amy holds a Bachelor of Commerce from Queen's University and an MBA and MPH from UC Berkeley. Thank you, Amy, for being here and for sharing your expertise with us. And our final panelist is Kimberly Kim Diaz-Scott, who is the Vice President of Policy and Communications at NIFRA, the National Family Planning and Reproductive Health Association. Kim has extensive experience working on state campaign efforts and spent the last 2 years working with America Votes as the National Deputy Director of States, working toward progressive policies and elections. In the most recent election cycle, Kim led campaign efforts in 4 states, and during the 2020 presidential cycle, she was the state director for Elizabeth Warren's campaign in Florida. Before that, she spent 5 years as a director of public policy for the Florida Alliance of Planned Parenthood affiliates. She also worked in the Florida legislature for 4 years for an elected official who served as both a state representative and senator. Thank you for being here today, Kim, and we are so lucky to have you join us. Before we begin, I would also like to thank you, our audience, for being here today and for tuning in virtually. I invite you to ask questions for the panelists using the Q&A function at the bottom of your screen. This event will be recorded and available to watch on CAP's events webpage. And with that, let's jump into today's conversation. I'd like to pass this first question to you, Tara. Tara, can you please take a few moments to orient us to the current landscape of contraceptive access? With your thorough research and expertise in state policy, will you please describe what our contraceptive policy looks like now, particularly focusing on the state level?
Absolutely. Thank you, Kiara, Emily, Women's Initiative at CAP for having me here. So unsurprisingly, there's a lot of variation across the country, as Emily mentioned, the patchwork of states in her introductory comments. And at a high level, it's helpful to think about it as public health insurance policy, primarily through Medicaid, and private insurance policy, although there's overlap, of course, between the two. In terms of Medicaid, there are various eligibility pathways to coverage depending on the state you live in and the range of contraceptives and family planning services that have to be provided, vary depending on which one of those eligibility pathways you get coverage. but those services must be provided without additional costs, without cost sharing. So most states provide a good range of prescription contraceptives to enrollees, yet we know that some Medicaid enrollees do face barriers in the form of utilization controls, like making you try a generic first before having a brand name. In terms of private insurance, the Affordable Care Act's contraceptive coverage requirement requires that most private insurers cover the full range of contraceptive methods without cost sharing, and also puts limits on utilization controls. This also extends to enrollees in states that are in Medicaid expansion population for the states that have expanded Medicaid. Some states have worked to make this coverage, the ACA coverage, more comprehensive by passing their own state laws that, for instance, may require coverage for all contraceptives without a therapeutic equivalent, require coverage for a 12-month supply of self-administered hormonal contraceptives or OTC methods, as well as vasectomy. Emily alluded to some of this at the beginning as well. And so these laws are often referred to as contraceptive equity laws, but to make it a little more complicated at the state level, self-insured plans or self-funded plans are not subject to those state mandates. So it's just the federal regulations that they are subject to. So, you know, there's two broad coverage buckets we have, but according to analysis that was released by HHS's Assistant Secretary for Planning and Evaluation last year, there's still approximately 7.9 million women of reproductive age that are uninsured, with a disproportionate share of those being Latina, and nearly half residing in states that have not decided to expand Medicaid, have a Medicaid expansion. This could go down some with the recent plans to expand in South Dakota and North Carolina, who just decided to expand this week. North Carolina did. So that's a snapshot of coverage piece. And I also want to mention access briefly. We know that from data from Power to Decide that more than 19 million low-income women live in county without reasonable access to a clinic that provides the full range of contraceptive methods, and that barriers fall hardest on women of color, young people, people in rural areas. And recent research published in Contraception found that nearly half of more than 700 Black, Indigenous, Asian American, Hawaiian, Pacific Islander, and Latinx respondents encountered a barrier to accessing contraception in the past year. And that makes it, you know, just another reason why it's so important to have a well-funded healthcare safety net like the Title X family planning program, which I know Kim will talk more about, so I won't. But finally, I would be remiss if I didn't mention one of the other access points, which is pharmacies. At the top, we heard about pharmacist prescribing authority. In a lot of 10 states allow as Emily said, pharmacists to prescribe, but then there are other sort of authority models that many states have where they can work with a doctor to provide contraception in pharmacies, as well as the impending decision before the FDA to improve an over-the-counter birth control pill. So this provides more access points, but we need to make sure that there's not unnecessary restrictions like age requirements, and that there is, of course, insurance coverage. So I know there was a lot and I raced through it.
That was great. Thank you so much, Tara, for providing that overview and demonstrating how complex state policy can be and how it interacts with our federal policy as well. I'm going to pass the next question to Kim. So can you share, with your deep campaigns and policy experience, can you share a snapshot of the current political landscape in which these policies are developing, evolving, and taking root? What are we dealing with here?
Yeah, thank you for having me here and really giving space to discussing this very important issue. And I think what's helpful is almost a context of the pre-Dobbs decision landscape and then the post-Dobbs decision and how that has changed the landscape. I mean, we can start with Griswold v. Connecticut, right, in 1965, which is the landmark Supreme Court case that recognized a married couple's right to use contraception. Now that has become a core component for the legal basis of the right to privacy. Griswold underlies the right to marry, the right to use contraception, and now, the vacated right to have an abortion. And of course, in addition to the other cases that have recognized the right to access contraception. So this was in 1965, but over the years, federal policy conflation of abortion and contraception really began to harden with the FDA approval of emergency contraception in the 90s, followed by the approval of mifepristone for medication abortion. And so some anti-abortion advocates have decided that abortion is embryonic death, meaning that preventing a fertilized egg from implanting is how this opposition defines abortion. So from that time, the distinction politically between abortion and contraception is being erased. Then we have Hobby Lobby in 2014, which established the belief that a contraceptive method is an abortifacient, which is enough to trigger a religious and moral refusal protection, really without any regard to the actual science of contraception. So ahead of Dobbs, states like Missouri were already seeking ways to limit access to certain contraceptive methods. 17 states have some type of restriction on public funds for contraceptive services on abortion providers. So now we're in this post-Dobbs era, and Dobbs has put a host of essential rights, including the right to contraception, at significant risk. Even if a provider is not providing abortion care, a state or other private actor may assert that other services the entity provides conflicts with the state's abortion restrictions or prohibitions. And of course, that all depends on the state law itself, how aggressive attorney generals and district attorneys are in enforcing the laws, how officials seek to interpret their laws, how they enact additional restrictions on contraception and or family planning. I mean, even how people define contraception in their states can have a significant impact. For example, a state could consider that certain methods are abortifacients and therefore can be banned under Dobbs. I mean, if science doesn't matter in the courts, which is unfortunately what we're seeing in many court cases, then a state could claim or imply that all contraceptives are abortifacients. So we are now living the reality that Griswold could be dismantled. Justice Thomas has explicitly called for its overturn. In Dobbs, the rationale is that, abortion not being a deeply rooted right in the nation's history and tradition could be applied to contraception by lower courts, even before a contraception case would even reach SCOTUS, or despite the fact that Griswold is still in the books. And so we could see an expedited path to SCOTUS in the form of a stay or injunction pending appeal being sought, and SCOTUS not intervening, just like they did with Senate Bill 8 in Texas, and thereby allowing a clearly unconstitutional law to take effect. So this can be seen in many forms, right? It could be a direct challenge to contraception. It could be even an indirect challenge on non-contraception issues, such as marriage equality. And I think in response, we are seeing electeds both on the state and federal level file proactive policies to really enshrine the right to access contraceptives. There are bills that are popping up that are related to expanding who can prescribe, dispense, and administer birth control, how to expand access to birth control. I know a concept from Illinois and Connecticut is having emergency contraception available in vending machines on college campuses and others. And so, and in a provider perspective, as we saw kind of in the immediate aftermath of the 2016 presidential election, patients are still requesting the early removal and reinsertion of IUDs to extend their time frame that they have protections. And now we're seeing an increase in interest in vasectomy services. So it is a difficult environment for contraception, and there are strong coalitions that are actively working to push back against not just the policy or the legal pieces of this work, but also the disinformation around contraception. Really grateful to be here, especially with fellow panelists who are always giving me hope in the work.
Thank you so much, Kim. I want to switch gears a little bit to you, Amy, and talk about in your experience as a provider, and especially thinking about your current work improving access to birth control for underserved communities. Can you please share what gaps you notice or what you have learned exist for the patients you serve?
Yeah, it's a great question. And as the panelists highlighted, the policy landscape is so complex. So I'm sure we can imagine for an individual trying to navigate this, it can be incredibly challenging. And even before thinking about policy, for a lot of these individuals, they're largely disconnected with the healthcare system. So broadly across the US, 45% of 18 to 29-year-olds do not have a primary care physician. And so for these individuals, when they do want to connect with the doctor, if you're on Medicaid, a third of doctors don't accept new Medicaid patients. So even with coverage, it can be very difficult to actually find a clinician that's willing to see you. And once you're able to do that, the average wait time for a primary care physician to see a new patient is over 4 weeks. And that's even longer for an OBGYN. So what we see is that at every step of the process, there are barriers across the board for all women in the US that are even higher for underserved communities. And then when we think beyond that of how do you physically get to the clinic, what we often see is that for low-income patients, they most often cite that the lack of affordable transportation and inability to take time off of school work as significant barriers to actually getting to that doctor's office. And I'm sure you can imagine if you are an hourly wage worker and you are on a schedule that you might be getting from your employer every week or every 2 weeks, it's really difficult to actually set up an appointment 4 weeks out and know for sure that you're able to make it and not have any potential risk with your employment.
Thank you, Amy, for that response. And thank you to all of our panelists for those helpful and thorough answers. Now that we have a sense of kind of where we are currently and what the landscape looks like, I'd love to nudge the conversation about towards where we're headed and what meaningful changes we need to make for equitable access. So Tara, I will kick it back to you. What legislative changes and priorities are needed to make an impact and to truly expand and protect access to contraception? What do you see as the most pressing issues in your work as a researcher and advocate?
That's a great question. I mean, I think at the federal level, definitely more funding for Title X family planning program, which has been woefully underfunded for nearly a decade. However, a lot of the issues that Kim talked about with conflation of abortion and contraception has sort of gotten in the way of that increased funding. At the state level, you know, there's now 10 states that are holding out from expanding Medicaid, and you know, and in addition to giving people full health care coverage for all of their health needs comes contraceptive coverage. And so I think that can obviously make a big impact, given that, you know, 2 of those states, Texas and Florida, have very high populations. And then I know you asked me about legislative fixes, but I think there's actually administrative actions that states and the federal government can take to enforce existing law. So I mentioned, and we heard at the top from Emily, and you have some of these fact sheets on some of these policies about pharmacists prescribing, about contraceptive equity, the 12-month dispensing. And even in the states that are very amenable to these policies, pass them happily, governors sign them happily into law. So we are seeing non-compliance from them. And so, what Amy mentioned earlier about, just think about trying to get time off from work, all these other barriers, and then having to say the policy, but then like, are you going to argue with the pharmacist? I mean, you can, but like most people don't have the mental energy to do that and pull up the law like my boss has told me she's done. So, AG James in New York about 2 years ago sent a letter to insurers, to 3 insurers who there were complaints that they weren't covering the products that they were supposed to be covering for too many denials. So I think having more states put more energy into that and making sure that the laws that they have on the books are actually being enforced. And then at the federal level, I mean, yes, we have the ACA contraceptive coverage provision, which is amazing and is responsible for so many people getting the birth control that they need without additional costs and saving so much money. But we also know so many people have had the method that they want, that works best for them, being denied, having to spend so much time arguing with the company and maybe ultimately not getting the method that works best for them. The administration has put out guidance several times to let insurers know what they are supposed to be doing to comply with the law. And like just Monday, 91 members of the House of Representatives sent a letter to the Biden administration asking them to crack down on these violations. So it's a real concern. And then I would say one other thing that's a big deal for federal enforcement is Medicaid free choice of provider, which we see Kimberly shaking her head, guarantees that Medicaid enrollees have the right to receive family planning services from any willing and qualified provider. But a number of states have blocked residents from using their Medicaid benefits at, say, Planned Parenthood or anybody who is also affiliated with providing abortion care, and that has a big impact on diminishing the sort of healthcare workforce that folks feel comfortable going to for this type of care. So those are my big asks.
Thank you so much, Tara. And I think a lot of what you said will blend really nicely into this next question for Kim. So in your experience working with providers, can you please describe what complexities exist for providers and what you see as, crucial to supporting equitable contraceptive access?
Yeah, so I have the pleasure of representing a membership of almost 1,000 total members in NIFRA, from service and training grantees of Title X, which for those that might not know, the Title X is the nation's only federally funded family planning program dedicated to serving communities experiencing low income and uninsured people. So very excited to represent those members. And also we have administrators of Medicaid family planning expansions. We have family planning programs housed in state, county, and local health departments. We also have family planning councils, Planned Parenthood affiliates, and other kind of family planning organizations that are a part of our membership. So these members operate or fund a network of more than 3,500 health centers and service sites that provide comprehensive family planning services to millions of people across the country that are experiencing low income, that are uninsured or underinsured. And unfortunately, they are constantly thrown barriers in providing comprehensive family planning care. The politics of abortion already impacts contraceptive access. And so as I mentioned, there are 17 states that have some restrictions on public funds for contraceptive services because of abortion bans. Actually, Guttmacher research last fall showed that in Iowa, one of the states that's facing this restriction led to the share of patients who stopped using birth control go up by 2/3. And so it has significant impact on access. Also, Title X requirements are in some cases in conflict with state abortion bans, restricting providers' ability to counsel patients on the full range of reproductive health services. That includes abortion. There's 12 states, right, that have some type of total or gestational week ban, and that are state government grantees in Title X. That's, examples are Idaho, Kentucky, Tennessee, Louisiana, and a few others. And this leads to providers being confused about what they can and cannot do as it relates to options counseling and abortion bans in their states. Providers worry that their patients are losing trust in them due to their inability to provide referrals for all of the services that they should be able to access. In Texas, because of a federal court decision, Diaz v. Becerra, clinicians are not able to provide Title X funded services to minors without parental consent, even though Title X explicitly protects the confidentiality of minors using Title X resources. And this is a type of policy that breeds distrust and discourages young people from accessing the healthcare that they need. Providers are concerned that they may face felony charges if they provide IUDs and emergency contraception to patients if their state moves to consider classifying these methods as abortifacients. Just kind of given the cascade of crises, clinicians are concerned about a future when patient privacy is not respected, and really are wondering how can they best protect their patients in this moment. So these restrictions severely compromise our providers' ability to provide high quality family planning care. And so much so that many providers, as Amy mentioned, are seeing themselves pushed into advocacy, learning about a state legislative process, right, to ensure that their voices are heard and that they can also be a voice for their patients. And I think it's important for us at NIFRA to also provide them with those tools and resources to be as successful as possible.
Thank you so much, Kim. And Amy, I'd like to ask you, how do we build up a healthcare infrastructure that is supportive to reproductive care in general and contraceptive care specifically? What are your recommendations?
Yeah, thank you for the question, Kira. And first, I'm so grateful to all the folks that work in policy like Kim and Tara, because it is so incredibly important. And my perspective is much more on the care delivery side and really taking the perspective of how do we take a patient-centric approach to make sure that we can provide care in a way that also fits within their lifestyles. In some ways, my ideal is that patients and providers don't have to worry about all the nitty-gritty complexities of policies, and they can focus on the provider side of providing really high quality inclusive care, and on the patient side feeling like they're empowered about their bodies and empowered about the healthcare decisions that they're making. So I think that overall just is a really important approach, particularly in digital health, to make sure that the way we're building is always focused on the patient and how do we make sure it's as accessible as possible. So I would say kind of outside of the policy side, a couple pieces that are really important to take into consideration is what are all the different ways that a patient could interact with a provider? So for example, we've heard from a lot of our users that some of them don't actually want to do video consultations. They prefer an audio consultation or to be able to message the doctor asynchronously because they're in a setting where they don't have a lot of privacy. So maybe they live in a multi-generational household, or they're living with multiple other folks under one household. The other piece as well is that they might not have consistent access to high-speed internet, where video consultations then can create more friction in that process. So I think for us, that's one way to think about it from a patient lens of how do we make it really easy to use, and then complementing it also on the policy side, where we see that reimbursement can differ really greatly for telemedicine, whether it's video consultations, audio, or asynchronous messaging, and really thinking about how do we make sure we have the right economics behind the telehealth delivery so that we can provide services in a very efficient way and cost-effective way that ultimately also leads to better engagement and hopefully better health outcome for the patients as well.
Thank you, Amy, for uplifting such important points for patient-centered care, and especially in the telehealth setting, as it's such a new world for a lot of us. I would love to kind of put out a few questions for all of our panelists. So I'm wondering, what do you want the audience to take away from this conversation today as it relates to contraceptive policy, as it relates to really building up a world where everybody has equitable access to contraception? And Tara, I will kick it to you.
Yeah, well, I think I want everyone to take away that, there's 19 million women living in contraceptive deserts, and we know that the greatest barriers they fall disproportionately, right? They fall on LGBTQIA populations, people in rural areas, women of color, and young people, of course, as well. And so just keeping that in mind, I think when you are advocating or developing policy about who is most impacted by what you're trying to do, and listening to those communities, obviously, when providing recommendations, or don't provide recommendations without consulting the people who are most impacted.
Thank you. Kim?
Yeah, I think, the biggest takeaway is that contraception is an essential part of healthcare. Access to contraceptives is central to people's ability to participate equally in economic and social life, allowing people to make decisions about their families and their lives. And so really considering that equitable access for contraception is affordability, coverage, and also accessibility, which means a consideration for the ability to educate and counsel on the full range of contraceptive methods, not just what is handpicked and chosen by the government. It means considerations for streamlining the process to access birth control, taking into account the time people have to take off to go to the doctors, to get a prescription, to then go to the pharmacy and only getting a 1-month supply, and having to do that for the following months for a whole year. Considering the cost of childcare, considering the cost of travel, especially for people living in rural communities, and how can we make birth control accessible to all communities? And then also want to recognize that it also means, kind of accessing contraception free of coercion. Our country has a long history of reproductive coercion, and so the right to make personal decisions about contraceptive use and free of coercion is important for all, especially for those that are historically marginalized groups. And I think Tara, mentioned many of them, but Black, Indigenous, other people of color, immigrants, LGBTQ plus people, people with disabilities, people experiencing low incomes, and people living in rural and underserved areas. So just knowing what is behind, right, when we talk about access and equitable access to contraceptives is important. And just appreciate kind of a lot of the hope and unity in this work that we're seeing in, our providers and advocates in states fighting against all odds in difficult legislatures. We're seeing it in the coalitions that are keeping electeds and community leaders accountable on these issues. And just, also just seeing it in these efforts, right, to host spaces to have a dialogue around this issue and learn from each other. So just really appreciate being a part of.
Thank you for those great takeaways, Kim. Amy, do you have anything to add there?
Sure. So one piece I know everyone on the call, I'm sure, strongly believes in is just the importance of policy. And I think Kim described such important advocacy work that has been done by so many individuals across different communities. And I think simultaneously, there are a lot of opportunities for us to increase access already. So while the policy environment may feel at times a bit pessimistic, I think there's still a lot of innovations that we're able to leverage today to really think about how do we get care to people who need it right now. And I also think there's a lot of really exciting potential opportunities as well for public and private sectors to work together. And I'm so glad to be able to be on this call because one, I learned so much from folks working in policy. And I think as a private company, there's a lot that we can do to be able to make sure that we're one, adhering to these policies, making sure we're on the forefront of being able to provide education to our communities as well as our providers, and continuing to leverage technology to advance increase in access and making sure we're doing it in a way that is inclusive and equitable across different communities.
Great. Thank you to all of our panelists for such a thorough discussion. I would like to open up for our audience questions. We have a few. So these are not directed towards anyone in particular. So I welcome any panelist who wants to start to jump in. So the first question we have is, have there been any recent wins in expanding contraceptive access that you would like to highlight?
This is not particularly recent, but I think one piece, for example, on our side, as we work with our medical advisors and our physician partners, we've been thinking about too, how do we make sure that people feel equipped with everything they need? So starting for our doctors to also ask about emergency contraception as a part of birth control counseling, so that if people think it's appropriate for them, they can have an emergency contraception pill at home in case they need it in the future. And I think these are ways where we can think about it of how do we make it more accessible, recognizing, in the moment that someone might need emergency contraception, there are so many barriers, whether it's transportation, getting denied at a pharmacy, and having to argue for your right to be able to access emergency contraceptive pills. So I think for us is thinking about more preventatively, what are things we can do, like providing emergency contraception ahead of time. So I think it's something small, but hopefully, it's a small light in a somewhat bleak environment.
I mean, I think the fact that the FDA, there's finally a product before the FDA for over-the-counter birth control, the O pill. FDA advisory committee is going to review in May 9th and 10th. The date was just set or released earlier this week. And I think that's a big win because people in the space, advocates, many people who are here have been working on this for a very long time. So I'm hoping that we will be able to celebrate and actually walk into a store and see this on the shelves before the end of the year or sometime very soon.
Yeah, and I think to wrap up too, in a quick kind of analysis that we did on state policy on contraception, we saw that there is a significant amount of proactive policies that have been filed in this past state legislative session in several states instead of attacks against contraception. And so, and that's not to say that that's not happening on a legal side or in an administrative platform, right, for some more hostile states, but want to recognize that there's a lot moving in a proactive way to try to, again, enshrine the right to access contraception.
Thank you all for sharing those wins. It's great to hear some good news in what feels like a bleak time sometimes. So thank you all. The next question from the audience is, what can ordinary people do to help push back against disinformation about birth control and care overall?
I was holding, does anyone else want to go first? But I'm happy to answer if no one is going to jump in. I would say, oh, sorry.
I was saying go for it.
Okay. I would say, it all depends on how much time you have, right? Some people have more free time than others, but I would think keeping yourself informed, you can use things like, we have a site called Bedsider that has information on all the different methods that are available to you, accurate, what they do, what they don't do. And I think keeping yourself informed and sharing that information with your network is, one of the first sort of defenses in stopping spread of mis and disinformation. And I think for those who have more time and are able to be more engaged, it's being really honed into what's going on in your legislature. I mean, most state legislature sessions are very short, some are long, but most of them, many are just a month or two, and just sort of keeping an eye out for what bills are coming before the committee so that at least you can sort of get plugged in with the local advocacy organizations and go and share your testimony. And as Kim alluded to, there's a lot of states that have introduced positive or proactive policies this session, and we do have a map of some of those on a couple different policy levers, and I'm happy to share that in the chat so you can see what's going on in your state.
Yeah, please do share that. We would love to see that work. Kim or Amy, did you have anything to add on there?
I have just a very simple one, which is go out and vote. I think that's a really critical part of it, just to be engaged. And we recognizing that legislators have a lot of power in terms of thinking about what policies are put forward. So I think taking that first step to make sure whether it's, your local, state, or federal government, your vote is incredibly important.
I'm here to +1 both Tara and Amy on those.
Thank you so much. The next question is specifically, thank you for putting that in the chat, Tara. The next question is specifically for Dr. Fan. Are there best practices doctors use to try to ensure their patients feel like their privacy is protected?
Great question. Clarification, I am not a doctor, but I do work really closely with our physician partners or our medical advisors. I think it's really making sure that there's very clear information throughout the process. And for example, for us as a digital health provider, we also are really explicit in terms of the way that we protect patient information, the way it's that all the information is secure and encrypted, and also access where it's only the physician that is working with them has access to their medical information. And so I think making all those information very clear and accessible to patients before they are interacting with a clinician, and in our case, readily available on the FAQ part of our website. I think those are pieces that can really help people feel comfortable and feel trusting of their clinicians.
Great, thank you so much. And then we had a question from an audience member. This is not for anyone specific, so feel free to jump in. How is it possible with HIPAA privacy rule that abortion care is not covered under privacy?
I'm happy to jump in there. So I think it's definitely HIPAA covers an abortion procedure for a patient that may have an abortion procedure. So that is covered. I think maybe it's the confusion of the right to privacy, which is really the government's relationship or the government's oversight over this medical procedure. And so the right to privacy, as it is established, it basically stated that the government does not need to interfere in a person or an individual's right to access this procedure because of the right to privacy. So not related to HIPAA specifically, but it's more so what is the relationship of government with this medical procedure? And in this case, and particularly with contraception, right, that is also covered under the right to privacy through Griswold.
Thank you for clarifying that, Kim. That was really helpful. And then we have one remaining question for Tara, and it is, could you please share an overview of the timing for the over-the-counter pill decision?
Well, I wish I could, but what I know is that the advisory council committee was going to meet in November, I believe on the 18th. It got postponed. It was just rescheduled for May 9th and 10th. May 9th is great because it's Free the Pill Day. So if you all don't know about that, you should check out Free the Pill Day, which is a campaign to raise awareness of pill going over the counter. And there is the opportunity to submit testimony for that, written testimony for that hearing. So I don't know if others can speak to when the decision will be available.
Cannot speak to the decision, but I know it's due, testimony is due by the 25th of April.
Mm-hmm.
So that's a great way to engage in that process and that hearing and really being able to show your support for, kind of the advancement of over the counter. But I think, it's pretty arbitrary on the timelines after the hearing on, kind of how.
Great, thank you. We have about 5 minutes left, and I wanted to ask if any of our panelists have any closing thoughts or any final remarks they would like to share with us.
I can kick us off. So again, just really appreciate, the Center for American Progress creating a space to have this dialogue. And again, just seeing a lot of hope and unity in this work. And, if there are any questions about the work that NIFRA does, or you want to get engaged, feel free to visit the nationalfamilyplanning.org website, and you can get more information about our work and kind of what issues are surfacing for us.
Yeah, definitely want to second what Kim mentioned around just being very appreciative, having space in the setting to be able to discuss these really important issues around access and how policy as well as healthcare delivery play into that. One piece I'll add is from our perspective as 28 Health, we work a lot with nonprofits as well as other community-based organizations. So if there are opportunities for us to collaborate, for us to support you, please feel free to reach out, because we want to also work within the ecosystem to make sure that we can collaboratively advance access.
And I will just echo what Kim and Amy said about, I'm so happy to be here, be on a panel with so many smart people, smart audience, I'm sure. And, just being part of a great ecosystem of advocates, researchers, doctors, providers, entrepreneurs who are working toward a world where everyone has contraceptive access, which is super important, but it's important because, what it allows us to do, the bigger goal, plan our families, if we want one, or our futures the way that we see them for ourselves.
Great. Thank you all again so much. I think that is all the time we have today. So huge shout out to you all. Thanks for your time, for being here and sharing your vast expertise with us and being in this vital conversation. Thank you to our SVP, Emily G, for her opening remarks, our events and technology teams, Maggie Jo Buchanan for her support, and the entire Women's Initiative team for making this event happen. And lastly, thank you to the audience for joining. We hope you enjoyed today's conversation and will take with you a desire to push for impactful and equitable change in contraceptive policy. So thank you and have a great day.